You wouldn't buy a car without a seatbelt, a laptop without Wi-Fi, or go a day without your cell phone. Could a business survive without the internet? Then why are many healthcare providers and provider organizations still not connected and enabled to share critical clinical information digitally in the care of your friends and family? Welcome to Kno2fy, a podcast from Kno2. Join host Dr. Peter Schoch, Chief Health Officer, and Therasa Bell, Founder, President, and CTO, as they bring the profound impact of healthcare communication to life through frank conversation in understandable language and through real-world context. They'll demystify interoperability, helping you unlock the potential of healthcare communication at scale. You'll also learn the transformative impact of being Kno2 connected. Connect, listen, transform.
Well, hello, everybody, and welcome back to the first episode of Season 2 of Kno2fy. I was just looking through the Nielsen ratings, quite frankly, and what I saw was there's the Game of Thrones. It's still ranked number one, as most watched on a repeated basis. House of Dragon is starting to come up now in Season 2, and then there's us right behind them, Kno2fy.
Nice. I knew it. I knew we were leading the chart.
No, in all seriousness, we've had, I think, a total of about 18 episodes in Season 1. Excited to launch Season 2. Excited about our topic today. We've got a guest with us today. He's known to Therasa and I, but not known to you folks. We're going to talk about TEFCA updates today. Some big developments in the world of interoperability over the last several weeks. And we want to talk to you about that. Some of our visit to DC and kind of unpack that and the implications of all that, as well as some of the SOPs dropped. And today, to help us discuss through that, as always, is Therasa Bell, back for a second season as co-host of the podcast. Therasa, can you say a couple of words?
Well, other than I'm going to be offended for our other co-host based upon that you said that the world doesn't know him, and they actually probably know him better than us.
I'm okay not being known.
Other than that, excited to be back and we've had some kind of summertime relief here, although it doesn't feel like relief on the inside given everything going on, but really excited about what the next 6 months holds for interoperability, and we'll get into that today. So thank you, and looking forward to it.
That's great. And the person I'm talking about is no mystery at all, really, to us internally. He just, I don't think, has been a guest on the podcast
apparently
before.
To the rest of the
Matt
world.
Becker is with us today. Matt is our Vice President of Interoperability at Kno2 and has played just an incredibly important role over many years leading up to TEFCA and the development of QHIN and the launch of TEFCA QHIN here in July. But Matt, tell us a little bit about yourself, your professional journey, and then we'll take a break and get started.
Sure. And thanks for the kind words. And I'm just very excited to be on the first episode of the new season. So congrats to you all for that. Just a little bit of background on me. I've been in the health IT space for nearly 20 years now. I worked for a major EMR for over a decade, have worked for a payer in the past, but really had focused in the last, I think, 10 to 12 years in the interoperability space and on data exchange. Specifically, it's a great place to nerd out because there's so many challenges that can be done and solved, both from a technical level and a policy level and a national level, of where we really need to go to just improve patient care. And super excited to join today, but super excited to nearly be celebrating my 4-year anniversary at Kno2. I'm just kind of leading this effort to make sure that everybody in healthcare can get the data they need in the right time, in the right place, and in the right format. So excited to talk through what we're going to talk through today, but overall, my journey's kind of led me here and very excited to be here today.
Well, Matt, thanks. And I there's so much more to unpack there. And
of course,
Therasa, I know you're going to say something, but there's one thing that's important to me, and many of the podcasts, we don't show the video. Many of the podcast listeners don't know that I went to the University of Missouri for medical school, and Matt Becker also went to the University of Missouri for journalism school, one of the leading journalism schools in the nation. And so we have that in common, and you can tell he's much more polished than we are in his presentation and speaking. Therasa, go ahead. You were going to say something. I saw you raise your hand. I know you want to say something, so I'm going to stop talking.
just for those that can't see the audio of this, I have to raise my hand to find it like 5 seconds. No, Matt Becker, I want to add more to it. So yes, he comes from a major EHR that also happens to be the only EHR QHIN right now that's publicly known. So put the pieces together. But Matt has been a tremendous, incredible, can't give it enough words, resource for this organization. Both his experience and his personality and commitment to the audiences we serve just fits into the DNA. So as the founder, it was a very fortunate thing that we were able to come across paths with Mr. Becker. And I will also testify that he went to the University of Missouri for journalism school. And according to Matt, he was a news anchor, right, Matt? At some point,
I was
some place in Louisiana.
For KTVE and KRD in Monroe, Louisiana, if you want to look that up.
I am trying to find it. I have yet to be able to find a clip of you doing a news anchor, but I love it. So he's been incredible. I'll say to our audience out there, both prospects and partners that are already partnered with us, he is the magic behind the scenes and is keeping things on the rails and does an amazing job advocating for our markets at the national level. How many committees do you serve in, Matt, today?
I can't count them. It's in the dozens.
So it's dozens. Literally, he's the voice of not only Kno2, but of our more importantly of our audience, and doing a fantastic job at that. So I just wanted to round out his University of Missouri experience, which I can't relate to, but yeah, that's great.
Go Tigers!
Not many people can. Not many people have that privilege of pedigree. To go to the University of Missouri. It's interesting too that you mentioned it because Matt, I know, is getting ready to get back on the road in the fall that we sit on to help lead through interoperability. So again, a big thanks, and Matt, really look forward to your input. And we really enjoyed our time together, the three of us in DC. Some very serious work that needed to get done there. But very much enjoyed that time together and want to share some of the insights, implications, and developments coming out of that meeting.
And I do want to say I'm very proud of what happened in DC, and I'm excited to share with the group what that is, and especially to you two for your contributions there.
Well, thanks. And I think that I'm hopeful that our partners and prospects listening will see the advocacy that was put forward for them for the right reasons in that process. So let's take a quick break. We'll come back, get right into the discussion.
Discover the freedom of being Kno2 connected. From Kno2, the leader in health information exchange and interoperability. Our cutting-edge solutions connect healthcare providers, improve patient outcomes, and streamline workflows. With Kno2, you can securely share health data across systems and enhance collaboration effortlessly. Join the future of healthcare with Kno2 and experience the difference. Visit Kno2.com to learn more. Kno2. Transforming healthcare, one connection at a time.
Connect, listen, transform. This is Kno2fy with your hosts, Dr. Peter Schoch and Therasa Bell.
Well, welcome back, everybody. We're really excited to get into the discussion today, and I think the best way to initiate that discussion and kind of talk about the in-person meetings in DC that we had at the beginning of July is really to talk a little bit about the roadmap to this point that led to that. And I think just at a highest level, we had QHIN applications, QHIN designation, QHINs that were approved for production, meaning they met all the appropriate testing for production. And as that process kicked off, the common agreement was being updated, the QTF was being put forward, and certain SOPs about how QHINs would work together and solve some of the problems were being drafted for review and ratification and put into place. But there was some tumult in the community of interoperability that we're all aware of that kind of went on in the early part of 2024 that had some impact to that timeline and specifically some impact to the treatment SOPs. Matt, I'm going to look to you as kind of our advocate and leader in that space. Is that a fair way to look at it? And if not, please give
It's
us the
absolutely a
impression
fair
of
way
how
to
things
look
were
at
developed.
it. Yeah, I think the biggest thing is this idea of a treatment standard operating procedure is brand new and kind of generated in the last, I would say, month and a half is even an idea. Treatment in interoperability and unscalable interoperability, especially with these national networks and frameworks, has always really relied on the definition of treatment under HIPAA. And this idea that we would want to take a more narrow focus, I think kind of came in part to what you said based on some of that background. But at the same time, is a brand new concept that was essentially dropped in the last 5 to 6 weeks that, the industry had to take a real quick reaction to in order to make it both trustworthy and equitable for everyone.
Yeah, and to not leave anything open. I mean, we're just talking about some of the concerns around trust in the framework. Is exchange being used for the appropriate purposes of treatment and all that it entails? And I think that, to your point, Matt, really good point, that led to an understanding and some critical tensions in the industry that needed to be dealt with upfront, that needed to be dealt with quickly, and that probably needed to have some compromise over what the historical milieu was. Trace, I don't know if you want to add anything more in terms of the color around the trust in the frameworks, the importance there, those kind of things, or anything else.
I think the word trust is really what we need to focus on, because as everybody knows, and we won't spend any time on it in this podcast, the turbulence at a national level has been, at the end of it, is the loss of trust. And if we don't have frameworks, I mean, the whole dependency of the frameworks working has very little to do with technology. It has everything to do with that we trust each other, meaning we trust each other as implementers. We trust that we're doing the right thing when we bring people on behind our gateways, that we're protecting the greater good, not just our business good, that we're protecting the greater good. And if trust is lost, and I'm not talking about technical trust here, security, I'm talking about truly framework trust. If that's lost, we have nothing. And this was I think your word on compromise is really important here. This was an effort to make sure that the work that's been put in the last 3 years to establish finally, from all the learnings, a national framework, that we wouldn't lose that and lose it from some just inappropriate activity, or however you want to look at it. Not going to comment on that, but we're not going to lose that. And we had to protect that and make sure that the trust was at least maintained, if in not some cases regained, as part of this work effort. Just want to emphasize the word trust, that it has more to do with the responsibility side of the equation than the technical side of the equation. And what that whole effort was, and kind of the 911 meeting out in DC to make sure that was protected.
I think it was, just from an optimistic standpoint, I think it was very, very good for the industry that we pulled together such a meeting so quickly based on what was already happening in the industry. And credit to the RC and the ONC specifically for making that happen and bringing nearly all of the QHINs to DC to participate in that. I know some couldn't make it, but at the same time, it was really, really great to see the industry come together in a moment in this particular moment where it was a great tipping point in the industry to make those compromises and make that happen in such a short
time. And set aside their business, right? Their business concerns, because that could have been the dividing factor for establishing trust. Is you can kind of say it pretty confidently for all the QHINs that participated both on site and on virtually, that everybody put those aside. They put aside their business concerns, and we got to protecting the trust for the greater good. And I'm proud to say that we have peers that have similar interests like that.
Yeah, I really appreciate what you both said in that regard too. I think that and I appreciate the distinction between framework trust versus technical trust, because and those out there might be, what do you mean trust? Well, I'll tell you, as a provider, before there was technology that allowed me to have an electronic health record and electronic exchange. When I sent somebody's record to another provider or shared information, my patient had to trust, and that provider had to trust, when he shared information back with me or she shared information back with me, that I was doing everything I could to share the information only with them, only the information that was necessary for them to do what they needed to do to improve the care of the patient, and that I handled that information with the utmost care, concern for the patient's privacy as we went through it. and there's a trust there that is absolutely foundational when you exchange information. So I think that's a great distinction. So let's flash forward DC for just a second, because I think I think we danced around it a little bit. I want to hit it head on. There were some tensions in the industry related to the kind of fracturing or fragility of the trust frameworks, and some of those tensions were those individuals who held data as stewards on behalf of other folks were uncomfortable sharing that data without making sure that we could testify or attest to, not testify, but attest to the fact that they met a true treatment purpose. And I think there was a general feeling that while the HIPAA definition of treatment had been a good definition for many years for the industry, at this juncture in time, it was too broad to allow the feeling of trust with data holders that need to be on the network for the exchange to have meaning in the first place. And that was one piece of dynamic tension there that I think is important to understand, and it's appropriate. It's appropriate. When I think about them being good stewards of the data and being good stewards to the people whose data it is that they're sharing, it's an appropriate tension. Matt, you want to add to that?
Yeah, I think the appropriateness is a great word, because when HIPAA was written, it was not written necessarily in the context of, and so that is one of the key differences that we're talking about here, because this exchange generally happens behind the scenes. It's automated, and there's not a human being checking at the end of the day for each transaction to say, does this meet the HIPAA definition? Can I release this information? And so one of the pieces that kind of we talk through is that, and establishing a level of trust on that level. And so what you'll see coming out of this is a lot of effort to make sure that we have a basic definition that everybody can trust, that automated exchange of information, and that patients can really trust. And I think we got to a good place.
Yeah. The only thing I was going to add to the Oh, go ahead, Tracy. Yeah, go ahead, please.
Sorry, I just want to add to what Matt said, is that because HIPAA was written before technology, short of just even these federated networks, was written before technology being what it is. It's not that it's inappropriate. I do want to emphasize, actually, it was written quite well for allowing appropriate access to patient information. But the difference here is once somebody has access, it's somewhat unfederated, meaning like I can go query under treatment and query these patient records, and we're asking those that are custodians of those records to be equally comfortable with whoever's coming through those front doors asking for this information, to be equally comfortable that they have established the appropriate privacy. And we've got people at different levels here. And when I'm accountable as a health system for millions of lives and records that are sitting underneath me, and I'm holding accountability to the patient for privacy, and I'm holding accountability to the providers, and now I have this network, that's a lot. That's a lot to consider. And this isn't about just one perspective. There's a lot of things at play here that have to be considered. Doing what we did in DC, to echo Matt's words, is it was the appropriate action to level the waters, so they kind of level the playing field here, shake out any concerns, and then start from here. Start from kind of a new set that everybody could get comfortable with, and most importantly, those that are custodians of the record could get comfortable with, and push forward after that.
Yeah, building on that a little bit, two comments. One comment is, I think Matt alluded to it earlier, around the ONC and kind of in the ARC and kind of managing through this, the regional coordinator being somebody that's hired on behalf of the ONC to implement TEFCA and QHIN. But I don't know if this happens in the same way without the public-private partnership formed under TEFCA, to be honest with you. I think it was a time in the history of interoperability where there needed to be government and private collaboration, intervention through a network under something like TEFCA in order to be able to do this. And I thought the ONC and RCE did a very, very good job managing through that. The other thing I was going to say, just on the definition of HIPAA as a provider, and Matt, your point is really good. That's one that Nikki made from the front of the room at the ONC as well, around I believe that the HIPAA definition of treatment is actually very good, and it is equally permissible and equally restrictive in the right manner to allow us to actually exchange what we need to exchange. But it was intended to be adjudicated on a case-by-case basis by a provider who is sharing those records, which is not the case initially when we go through these national networks where we have a treatment use case attested to, and then everything is just trusted that anybody who queries under that treatment use case is adjudicated in the same way. And so I totally understand that piece. And I think we started out positionally concerned about narrowing, if I'm being transparent, concerned about a potential narrowing of the definition of treatment under HIPAA. Not because we didn't acknowledge the dynamic tension we just talked about, but because we wanted to make sure that we didn't artificially narrow the definition, but that we actually looked at kind of the definition of a treatment relationship and what is that? Is that as broad as it should be? And can we do better at defining those terms? Can we do better at defining who a provider is or who an entity is, number one? And then number two, if we started out narrower, we wanted to make sure that when we went in there, we had a commitment by everybody that we were going to continue to progress the development of potential use cases moving forward, because we felt like that was critical for interoperability to actually support the health system moving forward. No better example of that than pop health, and I'm sure we'll get to that as we talk through this, value-based care, those kinds of things, but also assisted living, those kinds of things. So we'll talk through all that, but I think those are a couple of big points. I just wanted to be transparent about, we understood the dynamic tension, and we wanted to make sure and knew we needed a narrowing of the definition probably to get where we needed to go to start, but also didn't want it narrowed so narrow that it didn't apply where it should for people to receive care appropriately, et cetera. And then I'll say one last thing, I'll get off my soapbox. It was fun to sit and talk about treatment with a bunch of tech folks and administrators and not clinicians. I think there were some clinicians in the room besides myself in DC, which was nice to see, but it was just juxtaposition as a provider. Here are all these people telling me what treatment is, and they've never treated anybody. So, but it was a good education for me. Trace, it looks like you want to say something.
Real quick, yeah, I think you brought up a really good point, because and this has been a critical statement of the company that you've pronounced more than probably anybody in the company, is that communication is foundational to solving healthcare's biggest problems. So we as a company have this tension of going between finding the solution to meet this narrower definition to reestablish trust, but also making sure we are pushing hard enough that we're not losing sight of the necessary innovation that has to occur to save our healthcare system. So things like telehealth, virtual health, all these things that have to occur, because it's the only way that we're going to be able to deliver care moving forward. We can't lose that. Otherwise, we're going to go way backwards. And we couldn't lose that tension. So your words about, your words, I think, were spot on to say we had as attention as this company to say, we've got this audience to serve. We've got to keep our eyes on the future and somehow create that bridge between now and what we know is necessary for our healthcare system to survive and continue that on. So I'm echoing it, emphasizing it, really important, really hard role to play. I'm proud again to use Matt's word of how we did that, and look forward to the conversation.
Yeah, and I would even say that I would go so far as to say, and I know the three of us had talked about it at different times, and it's not melodramatic. It was an existential moment for the industry, not just interoperability, but for healthcare that we were facing into as we marched to DC. And the reason I say that is simply because of the things you said. If interoperability is foundation for solving healthcare's biggest problems, and it is, when you think about the exchange of information at the point of care for the purpose of treatment, and all the impacts that it has to patient outcomes, provider experience, clinical and operational efficiencies within the offices, it is absolutely foundational for the transforming our healthcare system to where it needs to go and solving some of healthcare's biggest problems. That's the existential threat on one side, that if we narrow the treatment definition too far, we can't do that. We can't support that. If we don't narrow the treatment definition far enough or intelligently enough, nobody wants to join the network, because right now nobody trusts the network, right? That was, I want people to understand, that was the existential crisis on both sides that we were navigating through with colleagues in the industry, ONC, RCE, our other QHINs. And I have to be honest, everybody did an admirable job of navigating those waters, refraining from the business interests that sometimes so often conflate the work that needs to get done. So I just don't want people to underestimate the importance of this little meeting with these QHINs and the ONC for 3 days in DC in the middle of July in 2024, because to me it was an existential moment in the industry, both interoperability and healthcare.
Totally agree. Well stated.
So let's talk a little bit about DC in general. Matt, you're probably the best person to lay this out. So when we went there, there were other things we discussed, but the dominant thing was the treatment SOP in TEFCA. And how was that going to differ from current national network exchange and the HIPAA definition of treatment? So I don't know if you want to lead into that and frame the conversation. And then I'd love to talk about the different concerns that we had, where we ended up with it, highlight a little bit of the advocacy in certain areas that we felt was important. So,
yeah, I think there was just a lot of swirl of, how do we actually get this done in an efficient way? And how do we, just to your point, Dr. Schoch, how do we not narrow this in a way that actually harms patients? And so I think coming into the room, that was my concern. And especially with some of the initial, here's what we're going to talk about, and here's a draft of what we're thinking about going into that, was extremely narrow. And one of the things is a great starting point for us, but it also kind of led into those meetings to say, we really need to make a stand for all of healthcare and make sure that we're getting cooperation. And I think a lot of people came in with opinions and making sure that their folks was heard. But at the same time, I think there was an initial concentration on the major players in healthcare, and rightfully so, because they are the major data holders. But at the same time, making sure that all of healthcare was taken into consideration was my main concern going into the meetings, and making sure that everybody from senior living to hospice to therapy to long-term care, all of that needs to be considered, because that is an entire patient's journey. And we're really harming patients if we take that away from what they're already used to today on national networks, getting that information, being able to intake these patients correctly, and being able to care for these patients quickly in such critical situations.
Yeah, I really like that, and I think I think it's critically important, no question about it. I think it's something that every QHIN had a unique perspective. I think that was helpful in the conversation to end where we ended. One of our unique perspectives was, and Therasa, I love the way you say this. I mean, we're connecting a constituency to national exchange in interoperability that is unique in the market, and doing it in a unique way. And it was important that we made sure, for the purposes of treatment, it was important that we made sure we understood where it was going to land for them.
Yeah, I mean, without revealing too much of what happened when we walked in that first day, and what was presented on the screen, and I know it wasn't intentional. It is a repeat of what happened with meaningful use, where we had large swaths of providers just completely forgotten about, like they don't exist. And again, it wasn't intentional, so I don't want to paint anybody in a bad light here, but when physical therapy, oddly enough, has requirements from MIPS and some call outs for TEFCA, and we walk in on Monday and they're not even in the eligible provider list that could participate in TEFCA, you can see the challenge that creates for us. And it's almost comical, because it wasn't intentional, but you're like, hey guys, do we realize what we're creating here? And so we had our audiences, which we represent all of healthcare, but everybody knows that we've got a very special place for the work effort we put towards these overlooked audiences in post-acute and therapy, EMS, dental, and vision, being very unique audiences that have never had the voice. And if I walk away more proud than anything, it is the voice that we carried in there. And, when we're called, I think I was called the most contentious in the room by the end of the third day. Some word was used to describe how loud I was. I'm proud of that. I am happy for what we represented, but those are the audiences that we cared about. I will say, with all that, and we probably should have given this shout out earlier, is that Dr. Pathy, the HHS team, the ONC teams did a fantastic job. What could have been a very volatile situation, governing and pushing through it, but hearing all the voices to the extent they could uniquely, and establishing everybody to have a voice and participating. So I do want to say that, but yeah, that was an interesting starting point to an ending point of where we came from.
Yeah, I think on the ONC thing, I think that's just another point to drill in on that. I mean, Mickey and his team reached out to us as he did other QHINs that had expressed concerns, expressed points of view, and so forth prior to the meeting, so that we could understand, so that he could hear from us one to one, and we could understand kind of where he was at leading into the meeting. And I thought it was very valuable, and I agree. I think they did a tremendous job navigating some very difficult times and reaching consensus very quickly on some big items that were necessary to get us started. And I think has laid a good foundation for continuing to kind of expand on that as we move forward. So let me talk about a couple things specifically and ask you guys some questions. So when we went into the meeting, you alluded to Therasa to the fact that some of the provider types that are already on Care Quality and Commonwealth and other national exchanges for the purposes of treatment weren't expressly called out, and so they weren't going to necessarily be able to be part of treatment. And I think it should be. And then there were some care settings that weren't required, and there wasn't a strong stance around population health and how assignment and attribution worked, allowing some population health activities and so forth. And I think those were some of the big areas that we talked through. So I want to talk about those. The one other thing that I would say just about the, I'm drawing a blank, it'll come back to me. But let's talk about those a little bit. And I don't know, Matt, if you want to start with you, just kind of what else was on your radar going in that we felt like we needed to address? And then let's start talking about how we addressed it and kind of where we landed.
Yeah, I mean, what was on my radar is really everything that you were saying, because the initial definition they came with, and I completely understand why they came with that initial definition, really just covered major ambulatory practices in healthcare institutions. And so coming into it, it was really trying to figure out how to get the bigger picture seen by the rest of the community of what they were omitting, not just our sector, but just all sectors of healthcare, just to take the business needs out of it and really understand where the patient's journey is in that regard and make sure that that's all included. And so that was at least the biggest part of my radar, was just going through those individual pieces from the time you get picked up by EMS to the time that you are back at your senior living center or whatever. Like, that entire journey needs to be covered, and all that data needs to be exchanged, because any gap there means that somebody doesn't know something that's critical to your care, and it informs all the additional stops along the way. So if something doesn't get transmitted from EMS to the hospital, that can have a massive ripple effect all the way down to everybody else that needs that patient's information. And just to make sure that entire journey was covered, that's the main point of that, because one piece of information lost is potentially really harmful to that patient for their entire journey.
I think
that's a really
to what Matt said there, went from before we went into those meetings, and what was in the initial set of documents and in the common agreement was an implicit definition of provider, which was taken by HHS and ONC, and it had a kind of a broad swath of what a provider was considered to be. When you walk in that door, it went to an explicit set. And it was, as Matt said, largely around physicians, right? Is that this is kind of the community that we're thinking about, and this is who we're going to put on there. Back to, by the time we were done, and the most proud moment for me is an implicit set that went back to a broader definition of people that are providing care from beginning to end of the patient's journey. I like the way Matt put that. So it wasn't just the physician in the middle. No offense, Dr. Schoch. It was beginning to end of this implicit list. So an implicit to explicit, where our alarm bells went off, back to implicit, an appropriate list of providers with a couple of exclusions, which we'll touch on, but it landed in a really good spot.
You're never going to offend me by recognizing my fellow providers across the healthcare ecosystem. The care I quarterbacked and the care I delivered was all part of a team-based approach. Yeah. And I think for any provider to not recognize that is folly, frankly. So let's talk about where we ended up. If we went in there, we had some ideas related to, hey, we needed to make sure that we were providing a treatment definition that allowed for the query of records in population health circumstances. And when I say population health circumstances, it is an interesting distinction, because there are operations in population health, querying for quality reporting, querying mass population data to do different things. But querying for an individual's record because they've been assigned to a clinician who is responsible for their clinical outcomes as well as their cost outcomes, so that I can outreach to that person and bring them in for needed care, That was something that was expressly discussed and really approved and included in the treatment definition, by the way, the definition. And that's a huge win. It's a huge win. And it was stated in such a way that it will prevent abuse for population queries and so forth. It was very clear about that. But it was also very clear that the intent to treat a patient has been assigned or attributed to you. A value-based relationship is part of that treatment definition, and I think that was a huge win. A huge win for healthcare. It is what was important to me. I spent 35 years in value-based care. It was a huge win for healthcare.
Yeah, and even from the outside, as just a tech nerd, like I think as a patient, that was really relieving to me, because as part of that journey, I don't always know when to reach out to a provider or what I'm at risk for or anything else. And knowing that there are programs in place to essentially look at my record and from an individual basis, have a provider look at me and say, no, Matt needs to come in for this, this, and this because he's at risk for X, Y, and Z, when I don't know when I'm supposed to have a colonoscopy, for example, to really prevent bad things from happening to me. Knowing that somebody's taking care of me like that from the outside, number one, is absolutely treatment. But number two, gives me comfort as a patient that healthcare is actually working for me rather than against me, which I think is a lot of kind of the appeal to patients and saying, hey, I know my data is being shared. I know that it's going through these different pieces of treatment and these different hops. But at the same time, I know and I have the trust that these folks are really trying to take care of me. And when I receive that phone call saying, I know you just haven't had your colonoscopy and we need to get that scheduled, that is that comfort to me that somebody is proactively taking care of me, and that should not be removed from anything that we're doing from interoperability standpoint.
Yeah, I love that patient perspective, and I appreciated everybody else in the room who advocated in the discussion around that as well. Teresa, it looks like you were going to say something there.
Yeah, but I think the cause and effect of that, because that was largely your voice, Dr. Schoch, that brought that sanity to the definition. And again, another proud moment relating it to the effect of that, and back to the statement of solving some of healthcare's biggest problems. Not only what Matt just brought out as one of the big problems is the patient's awareness, but also our provider shortage. If we think about, we all know it's a fact that we have a PCP shortage. So if we would have changed that definition to be very active, meaning I had to see that patient either within my office or in the last 30 days to be able to query for their records, we just basically took away the power of data from the PCP to say, I've got this population of patients. We've got a shortage of PCPs. The only way that they can effectively get in front of this is with data to know which patients I need to see and which ones I can say they're probably okay not seeing them, or tell them to go do something, I don't have to see them. That is solving one of healthcare's biggest problems. So we look at the cause and the effect. So you defining it, we get it, making sure it gets back in. The impact of that is wide. That is one impact, but that is a massive impact to getting in front of our provider shortage on many different fronts. And so I just wanted to point out the direct correlation to the things that we see as some of the biggest problems in healthcare.
Yeah, I think that's fantastic. Another one was just the making sure that the covered entities were inclusive to include all sectors of healthcare that are providing actual treatment under that definition, and that the provider types, the individual provider types were listed as well. That was huge because, as you mentioned, you went from this kind of broad definition of provider type and covered entity under the HIPAA definitions to something that was much more explicit and narrowed because it called out individual providers. And getting that language right to include the vast majority of any provider type or any location that would ever provide treatment services to a patient or healthcare services patient was a big deal, and a lot of conversation about that. And I do think this is one area we still have some work to do in. I don't know if you want to comment on that from an ALIL perspective, et cetera. Yeah,
I think it's important. So I don't think it's known by most that when you get to the assisted living, independent living, which is what ALIL stands for, senior living. So we talk about some of these senior living communities where it's truly independent living, but they may have some healthcare services that they render. Or you get more advanced than that, where you have an assisted living facility. That's where my grandma ended up spending her last few years of her life, where there's a lot of care given, but they're still somewhat independent. Not all of them are covered entities. And so that was a give that Kno2, because we do represent the EHR vendors that serve senior living communities and provide the tools there. that was a give we had to give because not all of them are covered entities, and it was hard to fit that definition back in without loosening the definition of provider. And so we gave in that area, knowing with the commitment of the broader group that we're going to turn right back around and figure out how to fit it in appropriately without loosening it too much that it risks the trust again on the framework. So that is an area of give, but it was appropriate, and we're going to come right back around and protect that set of providers because they are very active today, like on care quality, for instance.
Yeah, and one of the things I was concerned about coming out of the meeting was especially that of the circling back, because there was a commitment in the room that, we were going to review individual use cases to add on to this definition quickly. And I do want to, again, give props to the ONC and the recognized coordinating entity for this. They have essentially started the process of figuring out what that's going to look like and implementing that. So what you see in the treatment SOP is not necessarily what's going to be in reality in 3 to 6 months. It is going to be added to. And so while we are really concentrated on the fact that, there are a lot of big wins and a lot of pieces of healthcare that did get included, for folks that are not included, at the same time, there was some compromise, but there is establishing a process, and that is happening, where I don't think that's happened in the industry in the past. I think with some of these national frameworks in the past, there's been, we've written the rules and we'll revisit it someday, and that doesn't actually happen. The active commitment in the room plus the action taken afterwards specifically gives me comfort that these folks will have their voices heard and actually have their say in national exchange going forward. And I thought that was critically important to a lot of the discussion we were having.
Yeah, man, I really appreciate you drawing that point out, because I think it is absolutely critical in building trust. Quite frankly, building trust in the framework, right? Is that if we say we're going to do something like that, and we understand that healthcare evolves, we understand our definitions evolve. And just on that point about the non-covered entities in AL, IL, and senior living, specifically, it's not just those non-covered entities. There are other non-covered entities that were excluded that might be included now in current exchange frameworks. Those were the ones that we had the greatest line of sight to because of our network. But in reality, the discussion in the room, there was no consternation about whether they were using those records for treatment in the room. That wasn't the question. The question was, how do we ensure, the covered entity gives us a very clear line to draw around how privacy practices are handled. Non-covered entity, not quite so much. We probably want to have some more time to think about that. It wasn't that there was this thought that, people are using the network inappropriately. It was just, how do we handle it? And it was a time when we needed to draw very clear lines in some of the spaces, and that was how they did that. Guys, we've had a robust discussion, and please.
Dr. Schoch, I know you're going to wrap up here. One area that I don't want to lose track of, it was a nit, but I think it had potential significant impact as part of the definition of provider and part of the definition of, what treatment came to be. We also made sure that it included it, to the point of innovation, that we kept the word virtual, because it went down to telehealth as being a opportunity that,
really good.
Vendors or telehealth providers, that word was too narrow. And we had to go to virtual health because of some of the different care delivery models, and change that definition out to virtual health so we can continue to push into innovation, especially as it relates to our provider community. So the combination of the definition of how we came up with provider, and also the directory structure in TEFCA protects the trust and allows for innovation like telehealth and virtual health, and on some of these other new care delivery models that are critical, again, to saving our healthcare system. So I didn't want to lose track of that. Again, just a small set of word changes, but I think has substantial impact down the line.
One other thing, too, that I want to make sure before we go to break and then come back to wrap up, we've talked about the definition of treatment in part of that, and because that was the biggest part of the conversation that we had there, and I think one that we were the most concerned about going in. But there were other moments where advocacy, and advocacy doesn't always mean screaming and fighting. And I know Therasa said she was voted the most contentious, I think, by the ONC. I'm kidding. But I think we made our voice known. Yeah, that's right. She's on the no-fly list now and all that. It's really blown out into a big deal. But no, we made our voice known, not from a perspective of being a noisy gong or yelling and screaming, but really bringing awareness. Sometimes advocacy, the biggest part of advocacy is awareness. And what there wasn't was in that room, amongst all those esteemed individuals who are very accomplished in what they do, was a complete awareness. We didn't have a complete awareness of what everybody else did in the room and some of the things that we're dealing with. And so we were able to bring an awareness to a different sector of healthcare, to a different set of problems in healthcare that was very important to begin to solve for as a group, a larger group, so that they could be part of exchange. One of those was the USCDI and some other technical things that had significant impact and potentially a chilling impact to the ability of a lot of the healthcare sector to be able to get on TEFCA in a meaningful way, that we also were very vocal about and happy to say that we're able to influence some very thoughtful changes that allow a natural progression of technical capability and standards-based communication. So let's take a quick break, guys. We'll come back, get final thoughts from you guys, and then close it out. Be right back.
Hey everyone, my name is Matt Becker, VP of Interoperability at Kno2fy. I wanted to take a moment to introduce our connectivity report. Did you ever wonder who in your area you could connect with digitally and reduce the manual activities associated with clinical information exchange? Well, simply visit Kno2fy.com, click the link for connectivity report, then enter your name, email, and zip code, and we'll send you a report to show those providers and provider organizations already connected and waiting for you to join them. Take the first step to getting Kno2fy connected. It's free, takes less than 30 seconds, and will spark digital transformation that could revolutionize your business. There's even a how-to video to make sure you get the most from the report.
Connect, listen, transform. This is Kno2fy with your hosts, Dr. Peter Schoch and Therasa Bell.
Welcome back, everybody. We're going to wrap up the episode today, just kind of talking about TEFCA QHIN updates and the meeting in DC. Hope it's been informative for you. It was very informative for us. I think as we wrap up, guys, any final thoughts really around the implications of what happened in DC and how we move forward from there? So, Matt, I'll start with you. Any parting words or any parting thoughts? And then Therasa will move to you.
I think the biggest picture, just general progression here, is the fact that all of healthcare is taking a wider view with both the ONC, RNCE, and all the other groups that are participating in TEFCA. I think that is the biggest win that came out of it, is just this base understanding of everything that healthcare does and making sure that everybody's included. And that's the moment I'm most proud of, not necessarily for the rule specifically that was written, but for the awareness in the industry and the commitment of the industry to meet us where.
Yeah, for me, I think I presented this on our all hands call that we have every Friday. This was in the top 5 most important moments of Kno2fy and of not only ones I've been proud of, but also most important moments in our company's history. And I think for healthcare, what happened out in DC and establishing it. So I'm excited. I think it landed really well. I went into it with a lot of reservation and left with a lot of motivation, I would say, to continue to fight. This has been, I can say this for myself, this has been my life's work to serve the markets that we're serving. And between 23 and 24, these 2 years have been what I've personally worked for and privileged to be around folks like yourself to participate in that fight. But this has been my life's work. And the risk of going out to DC with knowing that could all be undone in a short set of decisions, we did not leave that way. And so, sorry to go on for long-winded here, but it was really, really, really important moment in the company's history for me personally. And thank you to you two for the insight, Matt, to your continued push, Dr. Schoch, to your insight and oversight, I would say, as a clinician to what we're doing as a company, and appreciate your guys' commitment to it.
Therasa, thank you. And I know Matt feels the same gratitude to your comments. It's really hard to follow that. I too think it probably is from an administrative perspective, it is probably the most impactful point in the history for me of healthcare and interoperability because of the interrelationship of interoperability to the transformational needs of healthcare moving forward. And I was incredibly privileged to be a part of it. And went into DC excited with a heavy heart to make sure that we had an enormous responsibility, because it wasn't around supporting a business model. It wasn't, to me, and I know to you guys, it wasn't around supporting a business model. Yeah, that's in the back of everybody's head, but that wasn't the conversation that we led with. And to the compliments to the group, I don't think that's dominated the group conversation. I think what dominated the group conversation is, how do we first have a network so that we can set about the process of changing healthcare through interoperability in the future? And I think we walked away with that accomplished, and a good road ahead to continue to build on it. I think internally for us, and I know the three of us have talked about it, Matt and I have been hard at work on it, the clarity that the definition brings and having some of that behind us allows us to move forward operationally in the company, and understand the impacts from legal agreements, understand the impact from a technical perspective of any of the things that need to be continually monitored, and to understand operationally how we can continue to do our part, and go above and beyond to make sure that we're upholding trust in the framework, by vetting treatment use cases appropriately, documenting those things, and processes around surveillance of use and all those kind of things that we'll take on, like all the other QHINs will, as part of our responsibility to build trust in a network. So really jazzed about it, and great to have been there with you all, and I think a great beginning outcome to where we're headed. So that's it for this episode, guys. Thanks so much for joining us. And Matt, thanks for being here today. Really appreciate it. And I can't say it any better than Therasa. We just appreciate you, both from a business and industry perspective, as well as our colleague at Kno2. So thank you
for having me for both this and everything.
Thanks for joining us today. That's a wrap for this episode. Please subscribe or follow on your favorite podcast platform to make sure you don't miss an episode. Get Kno2 connected today and set yourself and your organization free to unlock your potential. For more information on the value of being Kno2 connected, visit us at www.kno2.com. Follow us on LinkedIn or Twitter. Connect, listen, transform.